Always good. Okay.
Excellent. So that's
now we're going to move on to, so now we're going to move on to thinking about nephrostomies. Last time we talked about catheters, and this is nephrostomies and ureteric stents. Now, these are quite niche for urology, but actually you may see them in clinical care with medical patients with long-term nephrostomies, and just demystifying what they are and giving a bit of confidence in managing them can be helpful to all areas of clinical practice. So these are our learning outcomes for nephrostomy tubes. So we're thinking about overview, a quick run through some basic nursing care, about kind of care for them in the community, how to remove them, and also their indication in the first place. So this is what a nephrostomy is. So it's a radiologically guided artificial opening created between the kidney and the skin, which allows for urinary diversion directly from the upper tract into a tube attached to a drainage bag. So it's basically, instead of the urine draining down the ureter and into the bladder, it's coming out the side and into a bag. So it can be unilateral, one side, it can be bilateral, both sides. It may be a temporary solution for an acute issue, such as an obstructing kidney stone or something like that. It may be semi-permanent until they have definitive surgery, for example, or it may be a permanent option, for example, in somebody who has invasive cervical cancer or invasive uterine cancer or bladder cancer, where the ureters are never going to be salvaged. And this is a long-term solution to maintaining their renal function and drainage. So as I said, the rationales for relief of obstruction for various reasons. It may be urinary diversion if you're trying to do extensive surgery in the pelvis. It may be to gain access for therapeutic intervention. So for example, to begin a tract for the bigger stone surgery called PCNL, where you're going percutaneous through the skin, nephro, kidney, lithotomy, so stone cut. So you're working your way through into the kidney and trying to deal with a big stone there. So this can be a kind of first stage to try and create the tract to make that surgery more successful. Or it may be diagnostic testing, so trying to get biopsies or samples from the renal tract itself. In regards to nursing care, nephrostomy tubes should drain without occlusion. So a lot of this will be replicating what we discussed in the catheter, but that you want to always maintain unidirectional flow of the urine out. So you don't ever want it refluxing back in to reduce the risk of infection. So monitoring of the tubing and drainage bag is important to avoid kinking and twisting, and especially because of its location, it is on the patient's back. So if they're rolling and turning and lying, kinking and twisting can happen quite easily. You want the drainage bag placement below kidney level. So you don't want to be putting it up at their shoulder when they're lying down. You want it to be down maybe at least their waist, maybe even their hip or onto their leg to try and aid drainage. And again, you want to be emptying the drainage bag when 2/3 to 3/4 full so that you're not getting reflux. And in where we talked about catheter bags, you should be changing them every 5 to 7 days. 7 days is okay for nephrostomy tube bags. Once a week, trying to change the tube is appropriate. The bag, sorry. The patient should remain free from infection. So you want to just make the patient aware of vital signs monitoring. So looking for signs of infection, such as higher tachycardia, fever, anything like that. But also for the patient to be aware of wound inspection and just thinking, does it feel more tender or sore? Is it red or inflamed? And when the nurses are doing their weekly dressing changes, just are they happy that the nephrostomy site looks clean and free from infection? And fluid balance will be maintained. So especially when they're first had the tube put in as an inpatient, accurate measurement of urine output is important. Also, marking of the bags is important. Some of these post-urological surgical patients come out with bags all around the shop. So they have a urethral catheter bag, they have even sometimes a little bag on a ureteric stent. They can then have bilateral nephrostomies and bags coming out there. They can then have post-operative wound drains inside and bags coming out there. So labeling is really important so that we keep an eye on what all's going on and take out the right tubes at the right time. But also with any bags like this, good fluid intake is important to reduce risk of infection and maintain flow for the patient. In regards to the weekly dressings, ideally the patient sitting upright with the back exposed. They can lie on their contralateral side if you're unable to sit them up. You want to, as I mentioned, observe site for signs of infection and inflammation. The suture should remain intact. So there's two different types of nephrostomy tubes that get put in. One is it's called a Cook nephrostomy tube, where there is a little connector on the end that has a self-locking mechanism. So when the radiologist puts the nephrostomy tube in, they then pull this string and tighten it around the locking mechanism, and that actually sutures the tube in place. Otherwise, it looks a bit like a chest drain or an anesthetic drain, where you put a little suture through the skin and then wrap it around the tube itself. But you want to make sure that the suture, either the one that's through the skin attached to the tube or the one that's part of the locking mechanism, remains intact. And that's just to try and stop the tube from slipping out for the patient. You want to perform the dressing change using an aseptic technique, always, of course. And you're going to be applying a new sterile dressing once weekly, or if required in between, so if it's got wet or loose or dirty. And that new sterile dressing, once patients are established with nephrostomy care, that can be done by a carer or by a next of kin. Doesn't always have to be nursing, but they need to be trained how to do it cleanly and well. You also want to document the condition of the patient's skin, when you did the dressing change, what dressing you used, and any difficulties, and a plan for the next change. When it comes to drainage bags and sample collection, similar to urethral catheter, when you're first taking a sample, you want to clamp the actual tube, the actual nephrostomy tube that's coming out, and then you're going to disconnect the drainage bag, and we'll see some pictures of that in a moment. But you're then going to clean the connector hub with an alcohol wipe, and then you just unclamp the tube and allow the urine to drain out into collection bottle. So there's not the same sampling port that there is within the urethral catheter bag. So you do just need to allow the urine to drain, and realistically it comes out in drips. It just goes drip, 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 drip into the wee tube. You're then going to apply a new sterile drainage bag and connector. And again, you're just going to be careful not to touch too much of the connections unless you absolutely have to. Try and keep a non-touch technique, bringing the two ends together, but holding them slightly further apart. You then want to document the time of the bag change and if the sample was obtained, and if there are any difficulties and when you're planning to change the bag again. So this is what I mentioned about the tube. So here's the tube sitting within the renal pelvis and coming out through the cortex of the kidney, out the skin, and then this is where the connection happens. So this particular type of one here is going to be one that's going to have a suture in the skin, holding the tube in here. And then this is the connection point. So you're going to pull the bag off, clean the connector, and just allow the urine to drain into the collection pot. The other thing that we often get asked to help with is flushing the nephrostomy. So this may be that if the patient notices that they're feeling a bit uncomfortable, if there's a bit of bypassing at the site of insertion, or if it's noticed that there's a poor urine output from the nephrostomy bag. So again, similar process, patient sitting upright, if you can, clamp the tubing, disconnect the drainage bag, clean connector hub, and then at this point, you're going to attach a sterile syringe containing about 5 mils of sodium chloride to the nephrostomy tube. A normal kidney can only hold 5 to 7 mils of fluid at any one time. So any more than that will just put pressure on the kidney. So 5 mils is plenty. What you're going to do then is just gently infiltrate the 5 mils up the tube, and then again, just try and aspirate it out again. And that's basically just to try and dislodge any debris that is sitting within the tube, or if it's just that the tube has fallen against the renal pelvis wall or something and just needed a bit of a repositioning, sometimes that can be enough. After that, then you're just going to, again, carefully reconnect the bag onto the tube and just check that your sterile drainage bag and everything is reconnected appropriately, and make sure that you have clamped or unclamped the drain so that it's all draining appropriately. Again, document date, time, any difficulties encountered, and review date for next change. Now, it may be that, again, this is something that we can teach patients if they start running into recurrent difficulties with their bag not draining well, or debris, and you can teach them how to do this themselves. If you've attempted it on the ward and it's still not draining well, or you're not happy with the position, then at that point, we are going to get to the stage of re-imaging and potentially resiting if it's still not draining well despite attempted flushes. When it comes to removal, it's very similar to those who are familiar with removing acidic taps and pleural drains, or even central venous lines. Same idea. Make sure that the suture is removed, that you've disconnected the drainage bag so that you've got control at all times, that you've not got things hanging and swinging about the place. If you have the one that I mentioned to you about the little locking mechanism is within the end of it, it's literally just a twist, it says on it. You just twist it 180 to release the little suture. You will tell the patient that they will feel a dragging, pulling sensation, gentle rotation of the drain just to loosen the embedded tissue that may be there. And then placing a finger either side of the drain, you're going to just grab and just gently pull in a gentle traction, but sustained traction. You don't want to be tugging. It's a sustained traction until it's been fully removed. You then cover the site with sterile dressing and tape securely with a bit of pressure just to prevent any leakage. And then just make sure, check the tube itself. Does it look complete? If there's any ragged edges or anything like that, there's a risk that a bit has been left behind. You also then just want to decide if you're sending a tip for microbiology. You want to make sure that you have cleanly cut the end with sterile scissors and just literally drop it straight into a little sterile container and with a wound swab from the drain site and send it on to microbiology. So that's how to kind of take the nephrostomy sample if you need to. Again, document difficulties encountered and if you obtained any samples. And my thing's not moving on. Discharge advice, then patients should be given written advice on how to manage their nephrostomy tube at home and when to ask for help. They should be given sterile dressings and a take-home catheter pack, like we discussed with the bladder catheter as well, the spare drainage bag and overnight bags. And again, they should be referred to community nursing teams for ongoing follow-up. For nursing staff particular, if anyone's watching this from a nursing background, there are drain guard fixation devices for nephrostomy catheters that are really, really good, and they can be got free of charge, but you need to get them straight from manufacturer. So just see below a name and contact number, as they're not supplied currently via wholesalers and NI, but these are really good fixation devices for patients who have long-term nephrostomy tubes, because they just find it helps secure it all very well. Lastly, then we'll just look briefly at ureteric stents. The indication for these is emergency decompression of the renal system due to ureteric blockage. The nephrostomy can do the same thing. Which one you get depends on which hospital you're in or the skill set or the indication. So if you're in Craigavon site where we have urologists 24 hours a day, we're likely to put stents in. If you're in the Royal, for example, where you've got radiology 24 hours a day, then they're likely to get a nephrostomy. But ultimately the aim is the same, to decompress the urinary system. It can be a temporizing measure until definitive surgery, or it may be a long-term management for ureteric narrowing or compression, for example, again, maybe nodal disease where you've got compression of the ureter externally. The side effects of stent are that this curl here is sitting in the bladder and in the renal pelvis. So it can cause significant dysuria, which is pain on movement and on bleeding, movement and on passing urine, sorry, and it can cause bleeding just from the irritation. So these can often mimic urinary tract infections because they get dysuria, urgency, frequency from the irritation from the stent. So the best thing to do is actually to encourage them to take simple analgesia to make sure their urine remains dilute so that it reduces the irritative effect of acidic urine and also keeps their bladder kind of a bit fuller so that the stent's not rubbing in the same way. And if there is a suspicion of infection, make sure a culture is sent off to confirm that. Otherwise, these patients come in and out getting antibiotics for what is simply stent irritation. And that pain can be experienced loin, bladder, and even penile for male patients as well. So again, just make sure it is infection before you start giving antibiotics. But stent symptoms are very common, unfortunately. And when it comes to ureteric stent removal, there's two options. If we've decided to take the strings off a stent, then we go in with a little bendy camera and remove the stent that way. But there are stent and strings where if we know it's only for a 2, 3, 4 day period, that we leave little strings on the stent at the end. So it looks like two little blue threads coming out of the urethra. And that process, then we actually advise the patient to remove the stent themselves. So they remove the stent in the morning in the shower or bath, take lots of water beforehand, take a wee pain medicine such as paracetamol, and then again, just continue a steady motion, pull on the little strings and just tug. And they should see then this long blue curly catheter come out. Obviously, at any point, if they're not happy, they need to stop and seek help. If there's any resistance or they feel that it's coming out and it's causing significant discomfort. And if that's the case, then we will go in and deal with it and support them with that removal. But the patients often can do this themselves in a home setting, which is a good use of medical resource after surgery, that you're not bringing them back on site to remove a ureteric stent. That's ureteric stents and nephrostomies. Hopefully that has demystified that for you. And again, we'll be back another time to look at other core urological procedures and continue to create a library of learning for urology. Thanks very much.
Thanks very much, Laura. That was really good.
Okay, no problem.
Really appreciate that. And just to remind everybody to ensure that they have their attendance recorded, please complete the links in the chat below. That also provides Laura with feedback for her teaching, and also provides her with a PDF of her feedback. So not that there needs any improvement, Laura, in case anybody has any suggestions, but it was great. It was really,
that's great. Thank you. I'll see you in another couple of weeks.
Yeah, we'll see you in a few weeks. And I know you're pressed for time, but you get lots of thanks here from Tim and Pauline as well. And we appreciate it. Yeah.
No problem. I'm glad it's helpful. Okay, we'll see you again.
Thanks, Laura. Cheerio now.
Okay.
Thanks, everyone.
Bye.
I'm just going to stay on here to ensure that everybody gets the feedback form and has any issues with it. So if you need me, just drop a wee message in the chat and I'll help you with the feedback form if needs be. Thanks now.